Let's go ahead with the other cases and radiology. There is a case which is presented by Dalia. Dr. Dalia, please present your case. Thank you.
Good morning, my dear professors and colleagues. Good morning, my dear professors and colleagues. Now I will present the second case. It's a 2-year-old child presented with vomiting of 5 days duration and acute onset of bilateral lower limb weakness. Here, as we see, there is a posterior fossa isodense mass lesion on non-contrast enhanced CT. On zooming, it appears to be obstructing the fourth ventricle with subsequent mass effect and acute hydrocephalic changes with CSF transependymal permeation. On MRI, on diffusion and EDC, there is no diffusion restriction except for a small area which appears to be solid part on flare, and there is cystic changes, and it seems to extend through foramen of Luschka. As we see, I will put a pointer. As we see, it extends through foramen of Luschka bilaterally. On T1, it's hypo-intense with an area appears to be hyper-intense, which is a hemorrhagic area. On T2, it seems to extend into both foramen of Luschka, so it's a plastic tumor. On T1 post-contrast, it shows heterogeneous enhancement with mild peripheral enhancement. So we are dealing with a posterior fossa midline mass lesion occupying fourth ventricle and extending through foramen of Luschka and Mangingi with mass effect on the surroundings. Our differential diagnosis includes medulloblastoma, ATRT, ependymoma, and astrocytoma. Could you please scan QR code? Our case is ependymoma. Ependymoma is a group of glial tumors, most arising from the lining of the ventricles of the brain or from the central canal of the spinal cord. They account for 5% of all neuroepithelial neuroplasms, 10% of all pediatric brain tumors, 33% of brain tumors in less than 3 years of age. According to WHO, it's divided according to their location: posterior fossa, supratentorial, or spinal cord. Posterior fossa ependymoma, group A, which is mainly in infants and young children, and group B, mainly in adolescents and adults. Radiological features, they commonly arise from the lateral recess of the fourth ventricle, subgroup A, or from the midline of the floor of the fourth ventricle, subgroup B. Extends through foramen of Luschka and Mangingi, so it's called plastic ependymoma. It shows heterogeneous mass due to areas of necrosis, calcification, cystic changes, and hemorrhage. As we see here, it extends through foramen of Luschka and Mangingi. On CT, it's heterogeneous because of coarse calcifications, cystic changes. It is solid, hypocellular tumor, so it's isodense to hypodense, unlike medulloblastoma, which is hyperdense, with heterogeneous enhancement and hemorrhagic changes. On MRI, on T1, it's iso-intense or hypo-intense. On T2, it's hyper-intense, could have foci of hemorrhage and calcification with heterogeneous post-contrast enhancement. Differentiating point, which is diffusion, no diffusion restriction except for small areas of solid component, and may have diffusion restriction in hemorrhagic areas. On MRS, elevated choline creatine ratio as other tumors, while the most specific, which is a rise of lipid and lactate. Supratentorial ependymoma found within the cerebral hemispheres, either remote or abutting the fourth ventricle. Have similar characteristic appearance to posterior fossa ependymoma. Imaging findings can be remembered by 1, 2, 3, 4 rule. 1 in the first decade, 2P perilesional edema, 3L large lobulated lobular mass, 4C central chunky calcification with peripheral cysts. As we see here, there is a large mass lesion abutting the right lateral ventricle, solid component, peripheral cyst area, and as well as there is a large chunky calcification. Spinal ependymoma is the most common spinal cord tumor seen in both adult and pediatric population, with peak incidence in the fourth decade, more common in males, and increased incidence within neurofibromatosis type 2. It can occur anywhere in the spinal cord, however, cervical cord is the most common site. On imaging appearance, it's an intramedullary, causing widening of the spinal canal, well circumscribed. Unlike posterior fossa ependymoma, calcification is uncommon. Its long average length of 4 vertebral body segments is due to hypointense on T1, while on T2 it appears to be hyperintense with peritumor edema and a cap sign, which is a hypointense hemosiderin REN, as we see here. On T1 post-contrast, it shows inhomogeneous, strong enhancement. While myxopapillary ependymoma, it occurs within the lumbosacral spine involving filum terminal or conus medullaris. It appears well-defined, large, is sausage-shaped, causing posterior vertebral scalloping, as we see here, while small tumors tend to displace nerve roots of coda equina. So our case is posterior fossa ependymoma. On CT, it appears to be isointense, as it is a hypocellular tumor with mass effect and cause acute hydrocephalic changes with CSF transependymal permeation, so they insert VP shunt. On MRI, no diffusion restriction except for a small solid part here. On FLAIR, there is a cystic area, and the most important, it extends through foramen of Luschka. On T1, it's hypointense with area of hemorrhage. On T2, it appears to extend to foramen of Luschka and Magenzi, heterogeneous post-contrast enhancement. So our scheme, posterior fossa tumor, look at the location, fourth ventricle, and foramen of Luschka and Magenzi. So is there diffusion restriction? No. Cystic changes, hemorrhagic changes, calcification, so it's a ependymoma. Our take-home message, ependymoma and medulloblastoma have similar imaging features. So the diagnostic clue, location, ependymoma plastic tumor extends through foramen of Luschka and Magenzi. Imaging features, ependymoma is hypocellular, so it's isodense on CT. It's heterogeneous with cystic changes, hemorrhage and calcifications, no diffusion restriction except for solid part or hemorrhagic area. So don't forget to image the whole neural axis, brain and spine for any deposits. Thank you.